Morning to you, ladies and gentlemen. This is O.P. Yadav, Editor-in-Chief of Individual Thoracic and Cardiovascular Surgery, and we are in Chennai at the joint annual conference of the Asian Society of Cardiovascular Surgery and Indian Association of Thoracic and Cardiovascular Surgeons. It's indeed my singular privilege and pleasure to welcome Professor Raman. Jay is Professor of Cardiothoracic Surgery at the OHSU in Portland, Oregon, USA. Jay, we have been hearing of all the bridges that ECMO can be used for, bridge to transplant, bridge to LVADs. But there is a new concept of bridge to conventional cardiac surgery, which your group has started with. So would you like to tell me something? How did this concept evolve?
Yeah, so first of all, thank you very much for asking me here. But we had a patient who presented with severe mitral regurgitation due to a chordal rupture. And I got called by the echocardiologist, and they said, you have to take the patient to the operating room right away and fix the valve. And we were all set to do it. On the way to the operating room, the anesthesia team actually called me and said they had great difficulty in oxygenating the patient. They had trouble transporting the patient safely. They felt that it was too dangerous to actually proceed with the operation. And after some discussion, I was actually leaning towards operating on the patient anyway, and then maybe coming off on ECMO. It was already sort of 9 o'clock at night, and we came to a consensus that I would put the patient on ECMO, see if her lungs improved overnight, and then operate on her the next day. And as it turned out, we put her on ECMO, we cannulated her groin in a peripheral cannula, and we have beautiful cannulae available now. You can position the cannula, the venous cannula in the right atrium, and a good size arterial cannula. We supported her on ECMO for actually a couple of days till all her oxygenation improved, her lungs, we were able to dry her lungs out, and then proceeded with the definitive mitral valve repair, and she did very well. So that set us thinking, and within the next few months, and of course the subsequent years, we've seen about close to 20 patients now in 2 institutions, where the patients present with a correctable cardiac condition. So it's not like the ventricle is blown or they're being considered for transplant, but these are patients who might have a mitral valve, like a chordal rupture. It could be an infarct VSD. It could be someone with ruptured papillary muscle. So
what about LV free wall rupture?
We had one of those in one of these people who actually had a hemorrhagic infarction with infarct VSD, but also there was a free wall rupture. But all of these conditions where going in the setting of someone who's acutely decompensating is fraught with a very high mortality, it's actually a very good strategy to step back, put them on ECMO, let the dust settle, and then it's almost like doing an elective operation.
So how do you decide? What is that cutoff point at which you would say the conventional resuscitative measures are not working and operation is not a choice? So what should be the ideal timing for ECMO?
I think the moment you see that there's someone who's on inotropes going into surgery, that's a very bad sign, as you know. If someone is actually about to have a mitral valve repair and they're already on inotropes, the outcome's not going to be good. If the inotrope dosage is escalating and the heart is struggling or the oxygenation is struggling, the general circulatory state is faltering, these are all indications that you have to provide some kind of mechanical support. In the old days, we would just put a balloon pump in these people. But the balloon doesn't help with oxygenation. The balloon doesn't help with
tissue perfusion.
Not help. Exactly. So once there are signs of end organ or dysfunction or end organ failure that is evolving, I don't think you should wait for that to become manifest. You shouldn't wait for renal failure to actually
So we go early rather than late.
Early rather than late.
But then what is that point which you think is too late for putting a patient on ECMO?
I think if you have signs of liver dysfunction. So usually, as you know, for the liver enzymes to go off, it takes about 24 to 36 hours. So if you start seeing someone with a rising transaminitis and the INR is going up, you know that the liver's taken a hit. And if you wait long enough, the enzymes will hit, the thousands. But if you see the trend, putting them on ECMO may not reverse the condition. And so that, I think, is a contraindication to...
What are your cannulation protocols for these patients?
So that's a very interesting question. So we've routinely cannulated them peripherally. So usually one groin or the other, percutaneous, over the wire. And we tend not to use imaging, it's often done by the bedside in the ICU. And we also are quite pedantic in particular about putting in distal perfusion cannula in the artery below. We got away without it early in our experience, but then we got burnt by one case, and that always stays with you. So cannulation is peripheral. I think the other nice thing with the cannulation is we use the same cannulae to go on pump. We don't change cannulation at all. And
post-surgery back to ECMO through the same cannula.
And the other thing that's actually helped us a lot in managing these people is the strategy of low heparin use.
Yeah, that was my next. What's your anticoagulation protocol?
So we found, and this is now what we published in the Journal of Heart-Lung Transplantation, we had a group of 52 patients where we looked at low heparin use. So what we would do is conventionally use 5,000 of heparin to around the time of cannulation, and then run them on no heparin afterwards. Because the circuitry is bonded, heparin bonded, the cannulae are heparin bonded, and the oxygenator is heparin bonded. So putting them on heparin on top of that doesn't make a lot of sense, because it's not an open circuit, it's a closed circuit, and the blood is not being exposed to air and other things, which is what happens when we are on conventional cardiopulmonary.
This is irrespective of the length of time that you use it?
Yes. We've had people with this strategy that have been supported for over 3 months and no issues. So we actually compared it to a control group which had conventional heparinization. So obviously the bleeding complications were less and survival was better. So this was a beautiful way of using this in these patients where we bridge them to conventional cardiac surgery. So we give them 5,000 of heparin at the time of cannulation, no further heparin till we go and pump.
And full heparinization.
Then full heparinization, and then full reversal.
Oh, you reverse that.
We reverse it completely with protamine, and then just run them. The only caveat to all of this is you have to have a reasonable flow. The flow has got to be above, smaller patients is 3.5 liters, and bigger patients, it's above 4 liters. And it's a function of flow.
Okay.
And when we are weaning them off, we start infusing heparin again.
And what is the weaning protocol? Is it any different from the standard ECMO?
It can be, because often when you do the conventional procedure, let's say it's a good mitral valve repair or infarct VSD, at the end of the case, you'll find that everything has improved so much that for the most part, you're able to come off pump, and you don't need to support them on ECMO anymore.
So do you come out with ECMO on the operating table, or you wait post-operatively?
So that's, again, a very good question. It is completely dependent on the patient. So in a few instances, we were able to wean them off very successfully. And we just, in a couple of them, we actually decannulated and we were fine. But for the majority of them, what tends to happen is you're supporting them not so much for the cardiac issues, but now you've got a patient with disordered anticoagulation from being on even though we have not used heparin, they've just gone on pump, they've come off, the platelets are low. There are all these issues where you're giving them platelets, you're giving them FFP, you're giving them a whole lot of coagulation factors. And in that setting, preserving the lungs, preserving the right heart, actually ECMO helps a lot in that setting. Right. And so if you're on ECMO for another day or 2 or 3, it doesn't really matter, because at the end of that you can wean them off. And for, like this experience of 19 patients, all of them we were able to wean in some fashion. And we had very satisfactory.
Besides weaning, what was the post-operative results, discharge and survival?
So,
do we have any data?
Yeah, so we did 19 patients like this, and we was able to successfully wean 15 of them off.
Okay.
The few that we were not, all had liver dysfunction. So that's why this liver dysfunction stays with me. And the 2 that did not make it out of the hospital, even though they had successfully been weaned, were patients who had profound platelet dysfunction.
Okay.
And we could not work out what it was. We kept giving them platelets afterwards, but even weaning them off, taking them off ECMO, didn't reverse the platelet dysfunction. So I just think you have to be proactive in these people and managing the coagulation and anticoagulation. But for the most part, 13 out of 19 is very encouraging results. So definitely better than 50%.
And my last, I presume most of them are going to be VA ECMO, or is there some place for VV ECMO also?
No, these are all VA ECMO patients.
If the heart function is good, ejection fraction good, still you won't put a patient on VV at all?
No. I think the problem with VV is that the right ventricle, if it takes a hit for whatever reason, we are
in trouble. So, ladies and gentlemen, again, a new form of therapy, use of ECMO as a bridge to conventional cardiac surgery. Better to use it early rather than late in patients with correctable surgical disease who are in cardiogenic shock and at high risk for surgery. If you support them and resuscitate with ECMO for a couple of days, the results can be excellent. Please do not wait till we get liver dysfunction. Peripheral cannulation with low-dose heparinization is what is recommended by Professor Raman. Thanks a lot, Jay. It has been wonderful interacting with you.
Thank you very much.